Our last session in this block of time finds us with journalist, senior fellow, and doctor of public health at UC Berkeley, David Toller. You've written on behalf of ME/CFS for a long time. When I started looking at your work, frankly, I was overwhelmed. And now, on behalf of the millions that have long COVID, you're bringing your efforts into this world that overlaps with long COVID, ME/CFS and long COVID. David, the podium is yours, and I'll signal you when there's a couple of minutes left in our 20-minute period. After that, we'll have a QA session.
Okay, well, thanks. I'm really excited to be here. It's 8 in the morning in San Francisco, where I am. So this is what I'm talking about. This is who I am. I want to point out that I'm not a patient. I'm not a clinician or a scientist. And I got into this. So who am I and why am I here? I was many years as a journalist at the San Francisco Chronicle and a lot of work for the New York Times, including about chronic fatigue syndrome. So I've been after I was a journalist, I got public health degrees at Berkeley. And 9 years ago, in October 2015, I wrote a 15,000 word investigation of the PACE study, which I called Trial by Error. So basically, I wrote about the PACE trial, which was the study that appeared to show that cognitive behavior therapy and graded exercise therapy are effective for what was being called CFS, for ME/CFS. And I've continued. So I write news articles, I write peer-reviewed publications, I write irritating letters to journals, I am on social media, I give some talks. This is how to reach me, David Toller at Berkeley. I wanted to clear my conflicts of interest, which is many of you know, my position at Berkeley is supported by crowdfunding on Berkeley's donations to Berkeley. So I do have to declare the donors to support my position as my conflicts of interest. So this was the 15,000 word piece I wrote about the PACE trial. That was 9 years ago. I thought it would be a one-off because the PACE trial is a terrible trial and really an example of egregious research misconduct, I would say, and probably likely worse. So it didn't get retracted. Nothing happened, and so I kept going. And I wanted to talk in general. And what happened was I saw with long COVID coming in, there's some of the same people doing the exact same kind of bad research that they were doing for ME/CFS. And so I decided I needed to continue my project to sort of start dealing with that. So one of the issues in the this so-called biopsychosocial sphere, which is looking at these illnesses as not necessarily being driven by pathophysiological dysfunctions, but by psychological constructs or anxiety and depression or brain network malfunctioning. All these studies are all unblinded studies because they all look at interventions, which are hard to blind, psychotherapeutic interventions or therapy interventions. But the problem is they rely solely pretty much on subjective outcomes. So that's, how do you feel? Are you less tired? Are you feeling more energetic, and so on? And that's really a combination of elements in a study that leads to sort of an unknown amount of bias. If you're just giving people a therapeutic intervention and giving other people basically nothing, and then you ask at the end, in 3 months or 6 months, how do you feel, which is essentially what these studies do, you're going to get a lot of reasons why people might say, well, they feel better. But it may have nothing to do with whether they're actually physically able to do more, whether they're cognitively able to do more. It may be just a biased response. And the studies tend to find modest reported improvements, which suggests that those are really improvements that may have come about through bias. There's a reason why we use placebos in drug trials. It's because we want to make sure that people don't know what they're getting. Now, it's understandable that these interventions are hard to blind. And the problem is not that having unblinded interventions, the problem is combining them specifically with solely subjective outcomes, which is what a lot of these studies do. Now, there is a factor that it's hard to identify objective outcomes, given that we don't have any by at this point approved diagnostic tests, but there are objective outcomes of function that can be used. And some of these typical ones are a 6-minute walking test. These are standard tests, a step test for fitness, actigraphy, which is using a kind of Fitbit type device worn to check how far you've moved in the course of a day or a week, whether people are employed, whether people get off social benefits, whether they attend school. These are all objective outcomes that can be used to make sure that the subjective outcomes that are being reported actually are resulting in objective benefits. So we know that there's actually some benefit and it's not just a biased response. So in looking at the ME/CFS research, there's a whole list of ways that they go about manipulating data or making bad studies appear good. I'm not going to go through all of these. I'm just going to highlight in a few studies how these things have shown up as well in the long COVID research. So I'm going to go through a couple of studies and talk just a little bit about the individual aspects that they include. So that the long studies, there are a batch of studies of long COVID, patients with long COVID, however defined, and exercise and cognitive behavior therapy. So these are the treatments that were offered for ME/CFS and were long the standard of care. Now, these studies almost seem to generate positive results, and they always have positive headlines and news coverage emphasizing that exercise and CBT seems to be good for long COVID. The news reporting doesn't mention usually the basic problems about epidemiology that, or clinical trial design that undermine these reported benefits. And when you complain about them, it's very, very hard to get any retractions. That can be almost impossible. And getting corrections is extremely difficult as well. I've tried this. I've been able to get some corrections. But it's really, really difficult to challenge these studies. So I'm just going to go through a few. So this is one called Clinical Effectiveness of an Online Supervised Group Physical and Mental Health Rehab Program for Adults with Post-COVID-19 Condition. It was nicknamed the REGAIN study, and that's one of the habits of researchers these days to give all their clinical trials cutesy acronyms that really don't mean anything. So REGAIN, presumably you're trying to regain your physical and mental health is probably what the study means. This was a high-profile paper published in the BMJ. So that's formerly the British Medical Journal. So one of the ways that researchers overemphasize their findings is through over-extrapolation. So you study a population and you expand the interpretation of those findings to a group way beyond what should occur, or what the people that you studied. And that's a real problem in trying to figure out whether research findings apply to other groups. So in this case, the REGAIN study looked at people who had been hospitalized during their COVID episode. Now, hospitalized patients make up a small percentage of those who have long COVID, and they're not representative of the entire long COVID population because there's things that happen in the ICU or under intense hospitalization that cause their own set of damage or their own set of disabilities afterwards. So there's post-ICU syndrome, which is a known factor or known condition, and there's other things that happen in ways in which people who are in the hospital are different than those who are not in the hospital. So this was a study, a rehab study, and we don't need to go into the details, but some people got this, multi-part, episode, 10 or 12 or 15 episodes, however many, with a therapist, and other people didn't get that. And so already there's an imbalance. It's not really a controlled study because there's not much control between the two groups. There's not much parallel between the two groups. In any event, the abstract objectives say to evaluate in the abstract, the objective outlined is to evaluate whether a structured online supervised group physical and mental health rehabilitation program can improve health-related quality of life compared with usual care in adults with post-COVID-19 condition. And the conclusions say in adults with post-COVID-19 condition and online home-based, etc., was clinically effective at improving health-related quality of life at 3 and 12 months compared with usual care. The problem is that neither of those points out that, and these are the abstract is where people will look first to find what the meaning of the of the study is neither the abstract objectives nor the abstract conclusions mention this hospitalization factor. Now, it is mentioned in the abstract when they discuss who the patients are, but it's not mentioned in the places where people will look, which is what were we trying to find, the objectives, and what were the conclusions. The conclusions should have said not in adults with post-COVID-19 condition, but in adults with post-COVID-19 condition who had been hospitalized. That's the key factor. And without saying that, anybody who will read the study, who may not go into the fine print, which is in the text, will get the wrong message. It's why headlines are so important, in news articles as well, because many people read the headline in the first paragraph and get it wrong if the headline isn't accurate. This in the headline here, this also talks about post-COVID condition. It doesn't talk about hospitalization. So in the title, in the abstract, objectives and conclusions, we don't get the true story. So that's a real problem in terms of how this is reported, and it's also a real problem in terms of how it got reported in the media. Many of the caveat, and specifically that these were hospitalized patients, did not get reported. So in the same study, one of the ways in which researchers make things look better than they are is that they take findings that are statistically significant, but they're not clinically insignificant, and they sort of overlook the fact or downplay the fact that they're not clinically significant. In other words, the change may be it's a real change by the statistics that you've done, but it's so insignificant or so minor compared to in the real world that it doesn't actually have a clinical impact. So how did they do this here? The main finding, the main outcome here was something called the PROPR score, which was a composite of 7 subscales, which were quality of life. So this is considered a score for health-related quality of life. And the abstract claimed that this was clinically effective at improving health-related quality of life. Now, many outcomes have something that's called a minimal clinically important difference, which is the amount that's considered important between the control and the intervention arms. That's the amount. You want to see at least this much difference in their measures to decide if that was a clinically important difference. In the method section of this paper, they claimed that a range of 0.03 to 0.05 was the MCID, or the minimal clinically important difference, that had been found or determined statistically for this measure. When you looked at the reference for that, though, it turned out not to be true. The reference for this statement referenced not a study, but a page from from those who developed the outcome measure, saying that work in progress now recommended that 0.04 should be the MCID, and that if you want it to be conservative, it should be actually as much as 0.08. Now, in this study, they had 0.03. So because they had 0.03 and it was at the bottom range of what they claimed was the MCID, the minimal clinically important difference, they were able to claim in the abstract that it was clinically effective at improving health-related quality of life. But in fact, since the MCID was less than the was less than the range of 0.04, it was no longer within what could be considered a minimal clinically important difference. And so in the discussion section, they acknowledge all this to a degree, but they still have the word clinically effective in the abstract. And you're not supposed to be able to do that. You can't put in your discussion something that contradicts what you wrote in your method section and that contradicts what you wrote in your abstract. That's just not supposed to be done. But these studies do that. So that was one study, and this again was reported as showing, how effective this was, or showing that this was effective. But even on its own terms, the effect was so minimal as to be really virtually unrecognizable to the patients, we think, because that's what the data would show. But of course, my work is to respond to these things. I wrote a letter seeking correction with 24 colleagues, sent a couple of letters, and we didn't get a correction. They did respond to our concerns, but they basically dismissed them. So here's another study. This is a study, again, of cognitive behavior therapy. This was a Dutch study that targeted severe fatigue. And this was also in a major journal, Clinical Infectious Diseases. So what did this group do? Um, they had the bad objective findings. So many studies don't have any objective findings at all, but some studies have included actigraphy, which is that the participants wear something on their wrist or on their ankle to measure how far they've gone in the course of 2 weeks. In this study, they did that right after the therapy arm. They did that at baseline and right after the therapy was over, but they decided not to report those findings. They did acknowledge it in correspondence when it was pointed out that they had not included this. And it was known that they were going to use this because the protocol said that they would use this as one of their. They listed it not as a primary or a secondary finding, but they listed it among a group of other outcomes. So it wasn't a primary or a secondary outcome, it was among other outcomes, but they still used it. And they didn't have, apparently, so people reported that they were less fatigued, but they didn't move anymore in the course of a week. So that's problematic because it means that maybe they're not really feeling better. That's just a biased response based on the study design. Their responses for not including it were ridiculous. I call them dog ate my data excuses. One was that it wasn't a primary outcome, but it was another outcome. That's really not an excuse. You can't withhold data that would suggest that would undermine your findings just because you didn't list them as a primary or secondary outcome. And the main thing that they said was activity levels have nothing to do with fatigue, which is an astonishing statement. They claim basically that these findings are irrelevant, which begs the question of why they included it in the first place in the study. This is also a historical fact that the same senior author, Hans Knoop, has done this repeatedly when he's had actigraphy in studies for CBT. He's done this before in his research where they had findings for actigraphy for ME/CFS that were not did not support the subjective findings, and they did not report them in their main study. They only reported them years later. This is one last study, and I won't really go into it, but basically what they did was this is a Nature journal, Scientific Reports, and they claimed that they did a cross-sectional study design, and cross-sectional study designs are taking data at one point in time. They, by definition, cannot assess cause. Yet this study continually used causal interpretations. They were testing whether people with physical activity, they wanted to see if that physical activity reduces the number of symptoms during and after COVID-19 among young women. But the problem is a cross-sectional study design cannot answer the question of whether it reduces it. It can only answer the question of whether there's an association between physical activity and the number of symptoms. And we have to leave it to other research to figure out, is the physical activity affecting the number of symptoms, or is the number of symptoms affecting how much physical activity people can do? You can't use this kind of causal language, say reduce, in a study that's cross-sectional. However, this was used in the title of this study, in the abstract and in the conclusions. And again, this should have been caught by editors. It should be caught by peer reviewers, but it apparently wasn't. And again, this study could be hyped in the media as showing that that exercise helps when it doesn't show any such thing.
And they often are, David. David, could we segue to the questions now?
And that was the end. I wrote a letter, and this was my acknowledgments. So that was the end of my talk.
Yeah,
so yes,
I enjoyed your conversation recently with Vincent Racconcello. That was a wonderful conversation.
Thank you.
Let's see here. Over to the questions. David Toller, what is your recommendation for patients on how to deal with gaslighting by healthcare professionals during an appointment?
Well, so, gaslighting means in a way that the health professional knows, I think, that what they're doing is not right. And I think, to be fair to many health professionals, they're not doing the research. They're just reading the research and reading the news reports. So I think first it's important to try to assume good faith, perhaps, on your healthcare provider. They're not doing this deliberately. They do probably want you to get better. They just maybe don't know the research. I think one of the things that I've done, and I know that Ed Young had said this previously, in previous times, that I've had people tell me that they take my articles, or they take the letters published in journals, or they take something. They would take Ed's articles about long COVID and go to their doctor and say, hey, this isn't just me. This is a lot of people. So I think one thing is to just do your own research beforehand and make sure that when the doctor says you're just deconditioned, you have some information to counter that with. But, again, the doctors are not necessarily, they're listening to the research, and the research is getting published in high-profile journals, unfortunately. And so I think it's important to sort of understand that the clinicians are not the ones necessarily at fault here. Your clinician they may be a jerk and insisting on all sorts of things, but it may be that they're also misinformed. So unfortunately, part of your job as the patient consumer is to make sure that your professional your doctor is informed. And now that's very different. Also, different countries obviously have different healthcare structures and different options for how much flexibility you have from going to one doctor to another. If you have the option, definitely try to find a clinician or a GP who believes this is a thing and understands some of the processes that might be going on.
That's a great answer, David. And really, in many, many places, it does start with the primary care provider or the GP or an internist. And once you establish a good relationship, hopefully you can, and you receive a long COVID designation via code, then the ball starts rolling. And this is so important in terms of going on to the specialization that probably will be needed.
And keep excellent records of your own. Make sure that what tests have been done, what you've been examined for, what the doctor has said. If you're having some cognitive impairment, bring somebody with you to your appointments, which is a good idea anyway. But especially if you're having some cognitive impairment and you can afford, or somebody can come with you to be there observing, make sure to do that as well.
Very good. Our next question, what do you think of these bad, horrific views, which are still held by health professionals as to what helps people with ME/CFS or long COVID? Do they not listen, or are they not informed, or something else? I think you've kind of answered that, but if you want to add to it.
Well, I think that there's been a change. I think part of the problem has been, lack of medical education. I think people have, for some reason, doctors are like anybody. If you don't know something, it's frustrating. And so doctors either want to know what's going on, and if it's not, I assume that they often have negative self-image, or whatever. They don't want to be in the position of not knowing. And so I think it's also important to understand the psychological factors of doctor-patient relationships, in terms of the doctors need to feel like they know what they're doing. And so I think that probably plays into a lot of the kind of knee-jerk dismissal that patients experience. And let's make sure to be clear that these are illnesses that disproportionately affect women. So there's a lot of historical misogyny in healthcare, as there is in all aspects of society, that undoubtedly must play into this tendency to dismiss patients when they come in with these kind of complaints that can't be pegged to any particular organ damage, or that seem to be nonspecific, or that are nonspecific, and it's hard to figure out what's causing them. It tends to be an easier reaction to dismiss if it's a woman in front of the doctor rather than a male patient, I think. So I think that probably accounts for a lot of what's been going on for decades.
This goes to exactly the next question. Thank you very much, David Toller. Few people are dedicated to seriously studying the damage that the biopsychosocial model has done to patients with ME/CFS, and this damage can be extrapolated to other post-infection conditions.
Yeah, yes, I think.
I guess it's a statement and a point. Yes.
Yes, I think that's true, and I think that the whole long COVID situation has obviously. Everybody was so surprised. How could this happen? But everybody in the ME community, or ME/CFS community, knew that this was likely going to be the consequence. So now we're in a stage where everybody seems to recognize that, post acute infection syndromes are a thing. Like, it's a thing that we have to address. It's not just some few people, getting a headache or getting some confusion. It's like it's a lot of people. And I think this has made this more obvious now in epidemic form than when we see these things in sporadic form.
Cynthia asks or writes, yesterday the NIH ME/CFS research roadmap report was released. It was co-chaired by Dr. Bateman and Dr. Hansen. How can we get these timely ME/CFS research recommendations out into the world and funded immediately?
That's, I think, beyond my beyond my pay grade. I really, I'm not. I don't know. I don't know the answer to that. I can tell you what's bad about research. I'm not really that good about making government do things that they seem reluctant to do.
Yeah, Martin asks, in your view, what are the researchers' intentions behind these bad trial designs and overstated results?
So I think a lot of there's always this question: is this venal? Are these deliberately doing this, or is this just are they really self-deluded? I tend to think people are more likely to be self-deluded or to think that they're doing good work because most people don't want to do bad work; they want to do good work. Um, I think it's just in medicine, there's always people with unexplained symptoms. I mean, I think that's probably been true no matter what system you're working in. There's always people with unexplained symptoms. They're frustrating to deal with. It's confusing to clinicians and it's confusing to patients. And I think, um, we also have younger clinicians coming in who were trained in the same thing that their people have been doing for a long time. So I think for older people, some of the people I've been critiquing, they're later in their careers. And I think if what you're saying to them is not only have you done harmful things, I mean, not only have you done stupid research, all these 10s or 20, 30 years, but you've done research that's been harmful to people. And I think at anybody it's hard to take that in psychologically that your entire work life has been based on harming, doing research that's harming people. And I think it's very hard for anybody in a system to admit that it's followed the wrong path for decades. I mean, basically, everybody in public health who accepted the PACE trial as a quality piece of work really should be answering for that because it's a piece of crap. And so many policies were based on it. So, I think there's just paradigms get built in and they get reinforced, even though they may not be meeting the needs that they should be meeting.
Mhm. And Martin goes on to ask, how do these flawed studies manage to get through peer review in prestigious journals like the BMJ? Who's at fault? And I know that's more than a rhetorical question, and maybe we can all be like you and start writing the journals and saying what gives here.
I want to tear my hair out all the time. I'm like, how can you publish this? I mean, I don't really understand it. It's like, sometimes these studies are so bad and the flaws are so ridiculous. I mean, again, you do a cross-sectional study. You can't claim that you found that something reduces something else. You just can't. That's a basic thing. I don't understand how that gets even past the authors, much less a reviewer at a major journal, much less the peer reviewers and then the editorial team. It's really astonishing. And the refusal to take responsibility is also quite astonishing. It's astonishing. I don't really understand it as a human being who likes, as a journalist who's always tried to, correct inaccurate things when I write things. And, in public health should be, I mean, research should be the same. Um, I don't really understand how this happens, except that it's a breakdown of the entire peer review system.
David Toller, thank you so much for being with us, being with Unite to Fight 2024, and maybe giving us some inspiration that will enable some of us that can take action, actually take action.
Well,
So,
I just want to say, like as I said, I'm not a patient. I'm not a scientist. Like I'm not doing research. And I'm not a clinician. And so I think, what can everybody can contribute something. You can just look at a study and then think, oh, this doesn't make a lot of sense. I mean, that's basically what I kind of do. I mean, I have public health training, but I mean, basically, there are things people can do outside having scientific skill sets, within their skill set to help.
good. All right. Thank you, David, so much. And we wish you well. This has been David Toller as a senior fellow and doctor of public health at UC Berkeley in California.